Welcome everyone to the ATI seminar series. My name is Sophia Ahmed. I'm a general nephrologist here at the University of Alberta. I am absolutely delighted to moderate this outstanding seminar series today with Dr. Murdoch Leeies, who is visiting from the University of Manitoba. And I will take the opportunity to introduce Dr. Leeies, but first I'd just like to acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. We'd also like to thank Paladin, Astellas, and AstraZeneca for their support of the ATI seminar series. So now let me talk about our truly outstanding speaker today. Dr. Leeies is an organ donation, critical care medicine, and emergency medicine specialist physician. He's trained as a clinician investigator. He serves as the Director of Research for the Department of Emergency Medicine at the University of Manitoba. Dr. Leeies leads a collaborative program of research with a focus on promoting health equity in organ and tissue donation and transplantation. To ensure this work is informed by the population it aims to serve, Dr. Leeies has led the formation of a 2S LGBTQIA+ patient and public advisory team, which partners in the development of patient-centered research that explores the inequities that 2S LGBTQIA+ persons face in the organ and tissue donation and transplantation system. Through this work, Dr. Leeies hopes to generate knowledge that can inform the reformation of structural and systemic elements of the health system that upholds these inequities. His intersectional research program pairs with his clinical work as an organ donation specialist physician with the Transplant Manitoba Gift of Life program. Dr. Leeies extends his commitment to the principles of equity, diversity, decolonization, and inclusion, so EDDI, through academic and clinical service as the director of the EDDI for the Canadian Critical Care Society. So we are truly delighted to have Dr. Leeies join us today. And just before I hand the virtual mic over to him, I'd just like to remind participants that this seminar is being recorded, including the question and answer period afterwards. I've just asked some housekeeping. I remind people to keep their microphones off, and we're all on Zoom a lot, so please don't feel pressured to keep your camera on. At the end of Dr. Leeies' presentation, we will have a question and answer period. Please feel free to just lift your virtual hand, and I'll call on you. If you prefer to put your question in the chat, that's absolutely great. If you prefer to have your question asked anonymously, please just private message me and I will ask it on your behalf, but without using your name. So without further ado, we're delighted to welcome Dr. Leeies, who will be presenting on sexual orientation and gender identity in organ and tissue donation and transplantation, an opportunity to enhance equity and safety. So thank you, Dr. Leeies.
I'd like to just acknowledge also where I'm speaking to you from. So the University of Manitoba campuses are located on the original lands of the Anishinaabe, the Cree, the OJ Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past and the present, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. In terms of conflicts of interest, I've listed just that I receive grant supports from Canadian Blood Services and Health Canada. I thank you for your attention. And before we really dive into the subject matter, I also just want to acknowledge the incredible amount of collaboration and support that this program has benefited from Alberta. We've got collaborators, Dr. David Collister, Dr. Emily Christie, and Dr. Karen Doucette, all from your program, who have been really invaluable in helping to build this program of research. So I'd like to acknowledge them. So today we're going to provide a little bit of an overview of the research program. So I'm hoping that we'll appreciate existing inequities for sexual and gender minorities in organ and tissue donation, consider equitable policy revision options to support inclusion while maintaining system safety, and understand opportunities to engage in next steps in equitable policy revision in Canada. I'd like to start by really acknowledging and expressing my very, very sincere gratitude for this group. This is our patient and caregiver advisory team, and they've been fundamental partners in the development of this research program. And they continue to guide the ongoing work that we're participating in and designing, and help to set our future priorities. This is our sexual orientation, gender identity, in organ donation and transplantation patient caregiver advisory team. And so these people have all come to our group because of experiences that they have had in the system, in our health system that we work in. And they faced inequities and stigmatization in that system. And for some, this has changed the trajectory of their lives completely. And so their lived experience and their perspectives are really invaluable. Just acknowledging who the members of this group are, we have 13 patient and caregiver partners. These folks are living organ donors themselves, the caregivers of deceased organ donors, or transplant recipients. And they're all folks who have 2S LGBTQIA+ identities. But in addition to those identities, they're a group of wonderful people, and they're mothers, fathers, siblings, children, partners, husbands, wives. There's a diverse range of professions. We've got some nurses, physicians, students, educators, sociologists. It's a mix of both Canadian and American folks. And they're all driven by social advocacy and a desire to speak up about their experiences. And we really couldn't have developed this research program without them. So digging into a little bit of what is this program of research, and what are we trying to accomplish? I'll start just with 2 brief slides on background. If this isn't known to you, sexual and gender minority populations make up 10% of the global population by current estimates. The proportion of younger generations who are able to confront their identities and to come out is increasing with time. And so we're seeing much higher proportions of folks in the younger generations who are endorsing sexual gender minority identities. Very importantly, gender identity and sexual orientation are distinct and separate concepts. And so somebody could have a non-normative gender identity with what might be considered a normative sexual orientation. And the two things are not, part and parcel one concept. Very importantly, sexual and gender minority persons are not a homogenous group. This is a large, very diverse group of people. And while we sometimes use umbrella terms to, talk about populations or groups of people, it's important to recognize that while there are some similarities in this population, there are many more differences as well within it. And the different social identities that people have, the lifestyles that they have, and their lived experiences position them to have advantages and disadvantages compared to other groups and compared to people within their group. And there's a spectrum of privilege and power even within systematically oppressed or marginalized populations. We know, and I'm not going to belabor a bunch of stats on this, but that sexual and gender minority persons experience inequities in numerous health systems in Canada and beyond, not just in our organ and tissue donation and transplantation system. We know that actively researchers and community organizations, as well as patients, are calling for action to address these inequities that have been described. And if we think about the OTDT system, the core of many of these inequities relates back to the donation bans and differential policies that were introduced globally in response to the HIV epidemic in the 1980s. Policy revision and policy updates have not kept pace with our growing understanding of HIV epidemiology, detection, prevention, and treatment. And also importantly, inequities that impact sexual and gender minority folks extend beyond just this risk assessment, just this potential for increased infectious transmission related to HIV. And so these other inequities, are also important and warrant characterization and exploration. So, starting this research program, we recognized that some background and discovery work was needed to understand the lay of the land, understand the existing body of literature, and try to develop a map of the issues that are relevant to sexual and gender minority folks. So at the very start of this research program, we developed our patient and caregiver advisory team, and they've been involved in every element of the program and continue to be really active core participants in the research program. One of the first things that we did was to conduct a scoping review. And so we wanted to map out the literature that exists on the subject of a queer identity and any interaction with the organ and tissue donation and transplantation system. And so that's something that we completed and published last year. We also completed a environmental data scan looking at the ODOs across Canada, and we surveyed ODOs asking about different data collection processes, the types of sociodemographics that they collect and in what form they collect them. We asked some questions about training related to cultural humility or engaging with this equity deserving population. And I'll talk a little bit about some of those results coming up. We also completed a systematic review and qualitative evidence synthesis looking at sociodemographic variable collection and trying to define best practices, benefits, risks of enhanced sociodemographic variable collection, because we also recognized early on that limitations in our data, where in the health system we really don't collect a lot of social identity based information from our patients, that these really limit our ability to quantify inequities in our system or to monitor attempts to mitigate these inequities. And so that was, I think, a fundamental piece of work that we needed to understand in developing strategies to collect information in a way that's safe, patient-centered, and still provides meaningful, accurate data. We also engaged, maybe a little early in the discovery phase, but we engaged in some policy critique, and I'll present one of the reports that we used there. But I think this element of our program really helped sort of spur some conversation in the community, and so we'll come back to that work. In terms of work that's ongoing and underway, we're just in the analysis phase of a retrospective observational study looking at all of the referrals to our organ donation program in Manitoba for deceased donation. And we're going to be evaluating the impact of different increased infectious risk donor criteria on patient outcomes and trying to understand how these patients progress through our system. We've just completed and are also in the analysis phase of a series of in-depth interviews with our patient advisory team members. And so, in addition to the scoping review that we completed that looked at what's been published, we felt it was really important to understand the lived experiences and the beliefs and opinions of the people who have been through it. So people with queer identities and lived experience of the organ and tissue donation and transplantation system. We are about to launch, I think January is the target date in the new year, for our Canadian National Survey of the Queer Public, which is going to be administered as a part of a rolling longitudinal survey called Sex Now, which is run annually by the Community-Based Research Center. And we're excited and really looking forward to being able to understand more about the beliefs and opinions of the queer public in Canada, about current policy in organ tissue donation and transplantation, as well as about some potential policy alternatives that we feel might be more equitable. Similarly, we're developing right now a national survey of Canadian healthcare workers. So I would ask you to please watch your email inboxes for that. It'll be hopefully going out, I think, later in 2024. But to understand, your opinions about current policy, about potential proposed policy alternatives, as well as some of the current practices that people have. In addition to this, we're working with epidemiologists from Canadian Blood Services and Hema-Quebec to conduct a risk modeling analysis. In order to support policy change, what we're hearing from decision makers and stakeholders is that they're really going to need to see evidence that any policy change that we make is not going to threaten the safety of the Canadian OTDT system and is going to be effective. And so we're following sort of the same template that was used to inform the blood donation eligibility criteria and risk assessment changes that have been made in the last few years, where they've shifted from a gender-based risk assessment to a gender-neutral behavior-based risk assessment. And so some of these sort of steps were also used in order to make that change with Health Canada. And then finally here, we've got an economic evaluation, also looking at the economic impact of current policy and what we expect to be a benefit in policy alternatives. Ultimately, we're hoping to form a national consensus process, and we've been in discussion and partnership with these organizations: Canadian Society for Transplantation, the CDTRP, Health Canada, Canadian Blood Services, the Canadian Standards Association, as well as the Canadian Critical Care Society. And we're looking at reviewing and updating the 2014 guidelines that were published that made recommendations for the use of increased infectious risk donors in Canada, and talked about some different practice elements there. There's also some interventions that are in development. We are developing a national OTDT healthcare worker curriculum in cultural humility and 2S LGBTQIA+ matters specific to organ tissue donation and transplantation. This is going to be an asynchronous virtual platform that we're partnering with Canadian Blood Services and EGAL Canada to produce, and that's in development. And the hope is that this will help address that gap that's been described, which is healthcare worker training. So a couple of just key kind of resources here on some of these publications, just to review some of the key findings. I'm going to start with our scoping review. And so this was our scoping review to systematically review the existing literature and try to map out what the literature showed. And I've got a figure here. I'll warn you, I know PowerPoint presentation, this is not ideal to have so much text on one figure. So don't try to read everything right away, but I'll walk us through it. This is a figure really from that scoping review, and this is a summary figure that maps out the key harms and inequities that we found in the literature. Maybe not surprisingly, most of the published literature on queer identities and OTDT talked about inequities and harms. There wasn't any literature sort of celebrating queer identities or talking about the strengths of having a queer identity in the OTDT system. It was literature largely focused on risk of infectious transmission or advocacy-related literature looking at, thanks for sharing the link to that scoping review, Patricia, looking at different inequities. So in the center of this web, we see the two most common themes that we found in the literature during our qualitative analysis, and that was devaluation and stigmatization. And these were really fundamental and central to other inequities or harms that were described. Just to give you a bit of a lay of the land here, we're going to just go around the web like a clock. So we'll start at the beginning here. One of the key inequities is the increased infectious risk donor designation that we apply. So we classify anybody who's a man who's had sex with another man as being at increased risk for transmission of HIV or viral hepatitis, without requiring an evaluation of their specific behaviors. So this person could be having sex that is in no way increases their likelihood of acquiring or transmitting HIV or hepatitis, but because they're a man who's had sex with a man, they would be classified as increased risk. And there's really a limited evidence base. Common sense would tell you that there are subpopulations within this group that are not at an increased risk, and so we're overly discriminating against this population out of convenience. There are issues with inequitable access to donation. Certainly, men who've had sex with men are excluded from tissue donation, and we'll talk more about the specifics there. But there may also be inequitable access for the public in terms of access to transplantation. We know people die on the waiting list. Anything that we're doing that would limit donation, if it's not absolutely necessary, also limits access to transplantation. And there's morbidity as well associated with waiting for tissue products like corneas in Canada. If we continue on to the right, insufficient gender affirming care. This was highlighted very nicely in the literature, and this, I think, section really warrants its absolute own conversation. When we say that our criteria are based on identifying men who have had sex with men, there's a lack of precision in our system in being able to differentiate sex assigned at birth, which is the sex that the doctor assigns a baby when they examine their genitals at birth, which relates to biology, which relates to chromosomes, relates to external sexual characteristics. Capturing that as an M or F in our health information system, fails to identify somebody's gender identity, which might be different from their sex assigned at birth. And so then there's, a lack of clarity on how criteria like MSM would be applied to somebody who's transgender, gender diverse, or has a non-normative gender identity. We have seen, healthcare workers report that they have insufficient training to fully care for this population. We know that there's inadequate capture of gender identity in health information systems.
There, take it off. I should have done that earlier.
This identified
Someone should have told me.
Excuse me, Dr. Leeies.
Further.
Oh, sorry. Does everybody have can everybody check that their mic is off? Thank you. Sorry, Dr. Leeies.
No worries. Insufficient gender affirming care. So is also a large knowledge gap. How we interpret sex-based biometrics, very relevant in nephrology and looking at creatinine as a measure of GFR. How do these apply to transgender and gender diverse folks when they're on, when they're off gender affirming hormone therapy? What are other risks that being on gender affirming medical therapy might confer in going through the transplantation process? There's a lot of extrapolation of, we know hormones are associated with clots, so I guess, we assume that maybe increased VTE is a risk and talk to patients about that. But, this is an area that requires a significant amount of future research. And Dr. Collister is one of our collaborators, has led work in this field as well. Harms, to the system in terms of reduced supply of organs and tissues, which we mentioned in the inequitable access domain. And related but also separate from the queer community is HIV stigma. We really stigmatize HIV in a way that I think resonates and reflects back to the 1980s, when there was little understood about HIV, when treatment options weren't very effective, mortality was high. The landscape around HIV has changed completely. We now know that people who are adherent to therapy, who achieve complete viral suppression, can have normal lifespans. There's a body of research in the United States coming out of the HOPE research program where people who are living with HIV donate organs to recipients who are also living with HIV. And we're seeing excellent outcomes in kidney and liver recipients, who aren't experiencing worse infectious complications or worse organ failure complications. And we know in the community at large that treatment and preventative efforts are highly effective. So if somebody is living with HIV and they have an undetectable viral load, they have a 0% risk of transmitting HIV through sex. But we would still consider a seronegative sexual partner of somebody who's living with HIV and has an undetectable viral load as being at increased risk of having an occult HIV infection and transmitting it through donation. We don't yet know exactly how to treat pre-exposure prophylaxis with antiretrovirals in the donation system. In the blood donation system, this is something that precludes somebody from donation. It's going to be an area, I think, of discussion and kind of a hot topic moving forward. Disrespect of bodily remains. So disposal of bodily remains without use has been described as a harm to queer patients who wanted to donate their organs and tissues. And there's also an issue that I hope is going to be resolved soon, but this issue of rectal examination and deceased donation, the Canadian Standards Association guideline book recommends routine rectal examinations in any deceased male donors who are being worked up for donation to look for evidence of receptive anal sex. This is not a scientifically based diagnostic test. It doesn't have any proven association with HIV or viral hepatitis. And perhaps even more concerning, we really don't have a formal informed consent process for this element of the examination. And if you're not a gay man, you might not, I think, understand why this could be a very relevant examination. Certainly as a clinician, as a physician, it's no big deal to do a rectal exam on a patient. But if you're talking about a population that's been oppressed and marginalized, that's persecuted in some countries in the world with forced rectal examinations used to, criminalize and persecute these populations, it becomes much more relevant. And I would argue that informed consent is absolutely mandatory. And I think we're failing to meet the basic standard of informed consent by giving a general consent process for examination of the body. Saying we need to look at your loved one's body all over to look for signs of infectious transmission is different from really detailing, what you're specifically going to do. And then on the left, substitute decision maker suffering. The caregivers, particularly in our patient advisory group, it's been really amazing to work with them, but also really heartbreaking at times to hear the story of how the rejection from the organ donation system, right at the time when these people were finding out that their loved ones were dying, how that's lasted and impacted their lives and stayed with them. Something that myself as a donation physician hadn't really considered before hearing about this from the group, but I think there really is an opportunity to improve care for these people, and working with families, going through this process of consent, and then if there's a rule out sort of saying, okay, we're done, goodbye, there's no closure around that, and it's left people describing compounding grief at the time of losing a loved one, and frustration and agony at not being able to enact people's final wishes. And it's driven some of our members to take action in society. I mean, they've tried to make something positive out of this, but looking at starting charities that are supporting now good causes and fighting against what they see as inequitable policies, so that they can have some kind of sense of justice, I think is a really powerful thing to observe. And then finally, in the top left, transparency. So we talked a little bit about informed consent with the rectal exams, but I think, generally, we don't build into our informed consent processes discussions about inequities for equity denied populations. We're mostly focused on, helping anybody who wants to donate, which is important and is critical. But these communications have been critiqued as really being colonial in a way where, we're focused on, as a system, helping somebody make a gift, but also taking something from that person, and somebody else is benefiting from that as well. And so when these inequities exist and aren't confronted or recognized with our communication consent processes, that can be problematic. That can happen also in clinical interactions and even public facing content. I think very well-meaning, a lot of organizations kind of engage in Pride Month, have, big publicity campaigns, letting the queer community know how they can donate. But some members, I think, especially people who feel marginalized or oppressed, are also concerned that public-facing communication is one-sided and doesn't really do justice to the underlying issues. And so this was our initial map, looking at the published literature. This is what we found to kind of get this program started. Very briefly, just about the data scan of organ donation organizations, we also found that a minority of ODOs collect sufficient data to examine health inequities, certainly with an intersectional lens, looking at how different identities interact. But even for individual identities, I think most people who work in donation will know that most of our data collection occurs sort of midway through the ODO interaction. So patients might register for donation at one level and then are referred to the organ donation organization. And then if there's a rule out or something happens where they don't proceed down the consent pathway, there's very little data. And then when you get to the point of consent, there's a big kind of data collection period. So our ability to examine health inequities before consent are also quite limited because we don't collect full social identity data at that point. Very few programs reported collecting demographics on the substitute decision makers. And this is relevant for deceased donation because that's the person that you're interfacing with. And, I think you're making an assumption when you collect race-based data, let's say for the patient who might be a deceased organ donor, that, everybody else in their family is the same race, but that might not be the case. And so if that's relevant to your consent process or to the integration of a population-specific service into the care plan, we might also be missing, an opportunity there. And so we found lots of opportunities for improvement into the data processes that we use in the donation system. Things like variable definitions, what options are available if you have forms or you have an electronic health system to even enter gender identity, to enter sex assigned at birth, to indicate if those two things are different, to talk about sexual orientation or behavior. Again, healthcare worker training in sociodemographic variable collection and in cultural humility were identified as gaps, as well as a need for population-specific advocacy or support services. Kind of along the same lines as we were doing some of this discovery work, these are these policy-focused publications that I wanted to mention, and I think the first one will lead into a nice review of some of the policy relevant considerations in Canada that we can review very briefly. But we worked with the Community-Based Research Centre, which is the national queer research, advocacy and education nonprofit organization that's very active in this space. And we put out this report called Ending Discriminatory Practices in Organ and Tissue Donation and Transplantation. And I'll show you some of the elements there. And it got really picked up by the press, and there was a bit of a media sort of flurry around it. I think this paralleled with some of our patient partners who had been doing advocacy work on their own in Nova Scotia. And there was a bunch of news articles coverage there. And so it sort of spurred, I think, some conversation around this work. And we've also just recently published here in the center a cross-cultural policy comparison that compares relevant policies in Canada and in the US really highlights differences in our policies. And we argue in this piece that if these policies were truly data-driven, if our policies around how to assess the risk of a donor were based on actual data, they should be converging because we're dealing with similar populations. The risk profiles are similar. And so when there's really stark changes, we're questioning, what is the best policy and what are the relative risks and benefits. So this CBRC piece, I won't take too much more time, but I'll just kind of highlight some of these issues we've covered a little bit in our scoping review. But in Canada, we have a policy in organ donation where anybody who's classified as a male organ donor who's had sex with another man in the last year, the policy is cannot donate organs except through an exceptional distribution process. So meaning that the organs are labeled as being at increased risk for HIV and other infections based on, what some people say is a behavior, but I would argue really isn't. This is really an identity-based criteria that's overly inclusive and therefore excludes a lot of people that it doesn't have to exclude. In tissue donation, it is legal for US LGBTQ+ men who have sex with men to donate tissues, but in practice, they're routinely rejected before being tested because there's no exceptional distribution process for tissues, unlike for organs. There were issues where, the Health Canada regulations say that if a man has had sex with a man in the last year, in the last 12 months, that's the timeline where he's at increased risk. If it was before that, that's fine. In the United States, the FDA governs tissue regulations, and because many tissue banks in Canada are accredited through the AATB, they were adhering to the US guidelines, which is a 5-year ban. So it's an unnecessarily large period of time that doesn't relate to the predictability of HIV tests or of window periods for HIV or viral hepatitis. And so really is unnecessary. We've seen some positive change recently where the tissue bank in Nova Scotia has applied for a variance to AATB to be allowed to follow the Canadian guidelines, and they were granted that without losing any of their accreditation. And so I know they've offered to work with other tissue banks in terms of similarly updating and applying for those variances. And I think there are others in Canada, although we don't know. I think it's not reported anywhere in summary who's done that. The increased risk designation that we use, perpetuates stigma, I think, generally against queer people, and it helps support false ideas about HIV transmission. But at the same time, it may harm transplant recipients. We know that if somebody is offered an organ and they decline it because it's an increased risk organ, they have a higher risk of dying or becoming delisted. And so there's a concern that the stigma around queer people, around HIV, could be leading that patient to making a decision that really isn't in their own best interest, but is fueled by stigma. And so, that is very complex, I think, for us to consider in terms of how we provide informed consent and what kind of conversations should be had. And the US has made some changes that are relevant and interesting lately. I'll talk about those in a sec. Inadvertent outing, through the living donation process, where often a donor and potential recipient are known to each other. I think there's a concern for privacy there, and some folks have described being inadvertently outed as donors when they enter the system, because we require the recipient to be told that if they're being offered a donor or an organ from somebody who has an increased risk of transmitting HIV or hepatitis because of one of their behaviors, that could create an awkward conversation for, let's say, a potential donor who was not out to the recipient. But now the recipient has been told they're involved in something that's going to increase the risk of HIV. There's going to be, further questions if that happens. And so just being able to appropriately prepare for that period of time and consider privacy and at what point people need to know this potential outcome is needed. We talked about the reduced opportunity to donate tissues, and we talked about the rectal exams already, so I won't belabor those points. And I think we've kind of covered, looking at our scoping review, the issue of incomplete data collection. Talked about this issue where there's serodiscordant partners of people who are living with HIV, that they may be unnecessarily also discriminated against, and the need for further research and understanding, how to use sex-based biometrics in clinical care, particularly with transgender and gender diverse folks. So just to wrap up and highlight a couple of points from this cross-cultural policy comparison, looking at Canada and the US. The framework here, I think, important to understand is that the US has separate bodies that regulate organ donation and tissue donation. So the Public Health Service, I think it's called agency, regulates organ donation, and the FDA regulates tissue donation. In Canada, Health Canada regulates both organ and tissue donation. In all systems, a risk assessment of a living or a deceased organ and tissue donor is required. So we have to assess the risk of transmitting infection as well as other things, as we know, through donation, cancer, neurologic conditions, etc. And so all require an evaluation of potential donors for criteria that increase the risk of HIV and viral hepatitis specifically. These policies used to be quite closely aligned. In 2013 was the previous US update, and 2018 in Canada. But in 2020, the US Public Health Services Agency revised their national guidelines for organ donation. And they changed the timeline for any increased risk factor for HIV or hepatitis to be 30 days from procurement. So in Canada, we still use 1 hour, just 1 hour, 1 year. And in the US, they use 30 days. And this was in combination, this policy change in the US, with a recommendation to use NAT testing in all potential donors, regardless of increased risk factors, as well as to have NAT screening in recipients. They've also reduced the number of items on their increased risk list based on a lack of evidence of transmission. So one example that's relevant is women who have sex with a man who has had sex with a man used to be considered at increased risk. Now they're not, because of 0 cases described in the literature. So in Canada, we still use for organ donation variable timelines. It's 1 year mostly, 6 months for some criteria if NAT's used. Interestingly, if you've been exposed with a needle stick to somebody with HIV, but you have a negative NAT test, the risk period there is 6 months only. If you are monogamous, in a monogamous relationship with low risk sexual activity for 50 years with your husband, and you're a man who's had sex with men because you're 2 gay men, it would be 1 year for sexual contact, which doesn't really make sense, right? So these timelines are not based on screening test utility. And in Canada right now, our system, it's not policy, but recommends NAT testing for increased risk donors, but doesn't mandate NAT testing for all donors. And so I think there's variability in practice there as well. The US also has really focused on this issue of informed consent. And I think of the risk to the transplant recipient for refusing an increased risk donor organ when offered. And so they've said that the risk criteria need to be communicated to the transplant centers. The transplant centers need to tell the patients about this, but they do that in the first consent period, and no second specific conversation about the increased risk nature of the organ is required. So that's a change. As well, they specifically recommend that transplant centers should contextualize these discussions by including that the risk for undetected HIV or viral infection with a viral hepatitis infection is very low, but not 0. Talk about the efficacy of therapies that are available, and as well the fact that accepting organs from donors with risk factors might increase the chance for survival. So just in the last minute here, just the last 2 slides, there are some emerging themes that I just wanted to share that are coming out of some of this ongoing work that I highlighted. So one area that I think is going to be significant is sex-positive care for living donors and solid organ transplant recipients, particularly. We're hearing that our, especially queer solid organ transplant recipients, have found that their, immunosuppressed identity and the care that surrounds that comes mostly from, the transplant program, doesn't really overlap with things like sexual health care, primary care, and infections or virally mediated cancers that can be transmitted through sexual contact. But there's kind of this gap where they're finding it hard to access this care, where transplant programs are saying, well, it's not really, within our scope. And the, primary care team is saying, oh, I don't know what to tell you because you're immune suppressed. And so patients are seeking information themselves, online and in social networks, but have a desire and a need for this care. Gender affirming care, we know, is a big gap, as well as care for people living with HIV, both accessing transplantation in Canada, which has been done but isn't routinely done, and considering intersectional supports for queer patients and caregivers. That's been a significant finding for me personally, I think, in the work that we've done. And so one of the other really interesting things of the patient advisory team is people have said that this is kind of a sense of community that they were looking for, a group of people who have a queer identity, but also have lived experience of the transplantation system. These folks had sought community in, let's say, transplant recipient, circles, social networks, Facebook groups, but didn't really see their queer identities reflected, and so felt that there was a difference. And I think acknowledging that, and doing further work to help support a health system that can connect people with these intersecting identities, even just for peer-to-peer support, could be a really meaningful intervention. And just to conclude, so our goals of this research program are really equitable policy revision. We would like to see gender-neutral behavior-based risk assessments that are really relevant to the actual behaviors in somebody's life that would increase their likelihood of acquiring or transmitting HIV or viral hepatitis. Enhanced privacy support, standardizing informed consent, supporting safer spaces and clinical spaces, I think, is good generally, and there's ways we could do that in the transplantation system.
Oh yeah, I'm not.
Sorry, sounds like somebody's unmuted there.
Yeah, please. Thank you.
Increasing access to donation for queer populations, to transplantation for people living with HIV, if we were to support people living with HIV included as donors potentially, and destigmatization, I think, of the system generally throughout are our main goals. I know I'm running a little late here, so I think I'll end there, and happy to take any questions or comments.
Wonderful. Well, thank you very much. That was fantastic talk, and I will open it up. Really, yeah, I can see some applause, and I certainly agree with that. That was great. I learned a lot. The questions have been coming fast and furious to my chat. So I'll ask the first question just while we're waiting to see if anybody. Oh, looks like Anne Helpman has a question. No, you do not. You just thank you.
I just think as a speaker, it's nice if you see some faces. So I just
we are all here, exactly. So that's great. Well, thanks so much, Anne. So actually, just the first question actually came fairly early when you were describing the patient and caregiver and people with lived experience group, which I think is absolutely fantastic and integral to any and critical to any research or clinical team. One of the questions was the burden of learning about gender minority and sexual minority groups often falls to those who actually have lived experience, who will already, have enough on their plate. And wondered if you had any suggestions in terms of resources so that people can learn on their own. And so that's, I have lots of other questions, but I'll start with that one.
Yeah, definitely. There are a lot of great resources that are out there. There's not a lot that are specifically designed for organ donation transplantation. So, look for our upcoming curriculum, which is going to hopefully fill that void. But, there are many opportunities for basic sort of cultural humility and care training. I would say, look to your own institutions. I think there's a sort of a zeitgeist around EDDI focused work right now. And so many people are offering implicit bias training. There's a great resource. It's US based, but they provide a lot of like high quality free webinars and sessions called the Fenway Institute. I'll put a link in the chat here to their website. It's an excellent resource as well if you're looking at implementing something like enhanced sociodemographic variable collection in your program, or want to make your clinic spaces more inclusive. Some great actionable items there.
Great, and actually is like a perfect segue to the next question that's come, and please keep these questions coming in the chat. So you had commented earlier on the lack of collection of sex assigned at birth and gender identity, as well as sexual identity and other demographic factors in the clinical record. And then there's a question about, and I'm sure you've heard about this, but transgender broken arm syndrome. So someone who literally happens to be trans shows up with literally any healthcare concern, and it's immediately attributed to the fact that they're trans or they're gender affirming hormone therapy. And so do you have any experience of I'll use the word success with I'm not arguing this is super important. And I also don't want it to backfire. So just your experience.
No, I think that's a great point. You're 100% right. One of the key principles of enhanced sociodemographic variable collection to ensure that it's equitable and safe is that the collection needs to be universal. So we need to normalize this process of collection where it happens in the system. And it shouldn't be targeted. Right now, it might be surprising to think about, but many people say even for race, they check off a box on a form based on how the patient looks. They don't actually ask them to identify their race or their ethnicity. And same thing for gender, sex, and sexual orientation related variables. So one fix to that idea of really targeting or making trans or non-normative identity folks feel isolated is that this should be asked of every person. What is your gender identity? What is your sex assigned at birth? It can be asked at a certain time. It shouldn't be asked at every point through the healthcare visit. You come in to emerge and you're registered, and then your nurse asks you, and then the x-ray tech asks you. We have to think about what is the process of the patient's flow through the system along with their information look like, and when is the best time to ask and collect. Having those identities visible on forms or institutional materials also helps normalize. So if I'm a trans person and then I see on the intake form there's options for different identities, I see myself there and I feel included. Which might be a very different experience from coming in and being asked verbally what my gender identity is when I don't know that this is a normative part of our system. So those would be some ideas, I think, for designing processes to help support people from feeling, targeted.
Wonderful. So, okay, the next question is actually a bit of a deviation from what we've been asking, and talks about economic evaluation. And just paraphrasing what's been said, that basically some people can only be convinced that we need change when there's money involved. And do you have any plans or are you aware of any economic evaluations of what happens when you change these policies? I'll use the word for the better, like from a moral perspective. Your thoughts on that?
Yeah, I think we haven't seen that published in our systematic reviewing of the literature. We're planning to conduct an economic evaluation. I think, you could start thinking about the inputs into that kind of model. And, if we take tissue donation, for example, and rejecting tissue donation from, what would otherwise be high quality donors based on their queer identity. It's been published that we decline donation from thousands of Canadian Americans, sort of joint look at both countries, but thousands every year, based on our current criteria. We know that there's a shortage of access to corneal donation, and so if people are living for a prolonged period of time with vision impairment or blindness, there's a large morbidity cost there. And that would all be factored into an economic evaluation. So I think it's going to be really interesting to see the results. Any kind of model that you do economic evaluation with is going to be subject to its inputs. So we have to work to make sure that, this isn't the experimental sort of process, that really the model is hopefully accurate. But I think we've got the right team to do that. So I'm looking forward to see what those results are.
That's excellent. And Anne has just put in the chat, and Anne, I am also really horrible at Epic and Connect Care. But yes, I do not think in Alberta Health Services or Connect Care's our version that you can include sex and gender, but sex assigned at birth and or gender identity. I think they're just, I don't know which one we're collecting, I'll be honest.
They're not there.
One, and they're kind of used interchangeably, which is obviously not appropriate. So just in terms of wrapping up, the last question that's come through is, thanks for a great talk. And I think I reflect everyone when I say that, but this is what it says here. Thanks for a great talk. Do you have any suggestions for things that we can do today to make our clinical work more inclusive?
Definitely. I think the very first step is acknowledging that we all have the capacity to participate in discrimination, in marginalization. I think often there's this initial reaction to hearing about this work and to think, no, I respect all people, and so I really don't have a problem. That attitude doesn't help us fix systemic and structural problems. And it doesn't help us engage with patients. So I think step one is acknowledging that no matter how much good work we do, we can all be complicit in discrimination. I think I would encourage people just to start considering, from your patient's perspective, looking after them, how to make things more inclusive in your daily practice. So that can be things as simple as, sharing pronouns on a badge, figuring out how you in your own practice want to relate to patients about that. Not everybody likes the idea of saying, hi, I'm so-and-so, here's my pronouns, what are your pronouns? But there's other ways you can communicate, I think, with people respectfully and inclusively, like just asking, how would you like me to address you? And that gives somebody an opportunity to self-disclose. Showing ambassadorial symbols. Well, it seems like a small thing to have a pride flag, placed somewhere in a clinical space or on an ID badge. That's a symbol that's important for somebody who's looking for discrimination or not expecting to be included. When they see that, they know that you've done at least the amount of work to say, hey, we recognize that you have a real identity and it was worth me putting, this pin on. So I think those kinds of small steps could be a great place to start.
There we go. So that's wonderful. So thank you so much. And I just wanted, thank you for those excellent tips. And I just want to draw everyone's attention to the chat. Apparently you can include gender identity and sex assigned at birth in Connect Care. So I am going to have to learn how to do that because I didn't know. So I encourage everyone to read the chat because there's some great tips there. So with that, it's just 1 o'clock now. I really want to thank you very much, Dr. Leeies, for joining us today. It's been a fantastic session. We've all learned a ton. I'd like to also, just in closing, to invite everyone to join us next Wednesday, November 29th, for a virtual seminar session presented by Dr. Nader Jama and Dr. Corinne Marceau. The titles of the presentation are Osteochondral Transplantation, How Research Leads to Clinical Practice, and Comprehensive Tissue Center, Recent Developments in Legislation and Regulation, respectively. So, and the registration link is in the chat. So with that, thank you very much. Thank you, Dr. Leeies. We hope to see you back sometime soon, and wishing everyone a great rest of the day.